Welcome to Medical AI for Busy Doctors, Crucial Concepts in Less Than 10 Minutes. I'm Sarah Gerbauer, a physician and informaticist and the founder of Machine Learning for MDs. Today will be part 2 of learning to read a medical journal article with machine learning. This video goes along with part 1 that explained the most important parts of a machine learning article. And today we'll go through an example, which is deep learning-based available and common clinical-related feature variables robustly predict survival and community-acquired pneumonia. This paper is from 2021 from a Chinese hospital, and we're mostly using it because it's a fairly simple example of a machine learning algorithm and because community-acquired pneumonia is a common problem that clinicians see. The first part we'll go through is the methods section. Last time we learned that in the methods section, we need to figure out where the researchers found the data, how they prepared the data for the computer, how it was split up, and then how they passed the data through the model. Let's take a look at this methods section. It was a single-center study, and they collected the data from adult patients with community-acquired pneumonia for 8 years. Right away, we know where the data come from, so step 1 is done. Now we're on to step 2. How did they prepare the data for the computer? The first thing they do is create 12 data sets. This is different than splitting into training and validation sets. This is called ensemble learning, and it helps decrease the variance or difference between different predictions. One reason they needed to do this is that they had many more patients who had good outcomes than bad outcomes. They wanted to make the number of good outcomes and bad outcomes equal in the data set so the computer could learn from them equally well. They replicated the data so they had 12 sets of data with balanced positive and negative sample sizes. Again, this is just to help the computer learn from both the positive and negative equally. You can see in this figure the ensemble score predicted better than any single score. As a note, in this model, a patient outcome below 0.5 is good and everything above 0.5 is bad. The researchers used 62 clinical features for each patient as inputs. They divided these features into diagnostic and treatment features, just like any clinician would. They normalized the continuous number variables to between 0 and 1, which we discussed last time. For the classification features, like whether the patient received a certain antibiotic, they used one-hot encoding, which we also discussed. The vacancies were filled with the mean or the most frequent value. To go back to what we learned in the previous video, this matches exactly what we had talked about. These data were prepared in a standard way for the computers to consume them. To review, the continuous variables, which are often physiologic or lab values, are normalized so the values changed between 0 and 1. The categorical values are changed to one-hot encoding, and the missing data is filled with either the mean, median, or most common variable. Now we'll look for how they split the data up. The paper tells us the model training set and the internal test set were randomly divided in a ratio of 4:1. You can see this follows exactly with what we would expect for the training set. Now we expect them to tell us how they put the model and what kind of model architecture was used. Again, the model architecture, you only need to know what the class is, just like the class of drugs. You need to know the general concept, but not necessarily the specifics to know how it works. They tell us they use TensorFlow, which is a 3-layer, fully connected neural network. TensorFlow is a very common software package for neural networks, but assuming you don't know that, you can just Google fully connected neural network, and you get the definition to the left. You can see that it's a series of fully connected layers, and the advantage is that no assumptions need to be made about the input. That means you don't have to assume that your input is an image or not an image, so it's very broadly applicable, but not as good for specific purposes, for example, like images. This is similar again to what you saw in the previous video. Layers in a fully connected neural network look similar to our previous example. There are differences between these two kinds of networks, but the point of this exercise is really just to get the idea that yes, this is a kind of generic neural network. You don't need to know a whole lot more about it than that at this point. The next thing we see is that it mentions that there are 20 neurons in the first layer and 10 neurons in the second layer. And then the last layer has 2 neurons either for a good prognosis or a bad prognosis. Like we mentioned before, the information passes through the layers, like information would pass through neurons, and it gets flatter towards the end. And then you get a classification at the end of the model, very similar to what we've seen before and what we would expect. Now on to the results section. Remember, our questions here are, is the model valid? Did it perform better than previous models? And what does it tell us about patients? The first thing we want to know is how it performed during internal validation. And often we are shown how the model is able to distinguish conditions from each other, like cancer or not cancer, with something like positive predictive value. When you look at this next graph, you can see that the area under the curve of the ensemble fully connected neural network is 0.975 with an accuracy rate of 0.952. These numbers are roughly equivalent to percentages, so you can think about it as nearly 100% accurate for both, which is great. Next, we ask how the model did during external validation. And you can see in this paper that actually they did not have an external validation set. This means they only validated it on the 20% from their initial data set. This is not completely uncommon in smaller papers just because getting medical data is expensive and difficult. But it also means that we don't know how valid this model is for other data sets. We also want to know if it did better than previous models. They tested this fully connected neural network model with 7 classical machine learning models. This graph shows that the true positive versus false positive rate is better for the fully connected neural network. It's up top there in the orange. This is the table you almost always see, and it shows that the ensemble model did better in almost every category than the older models that they tested. Now we want to know what this actually tells us about patients, which is sometimes the hardest to figure out in these kind of papers. One question that the researchers had was whether any of the 62 features that they input would be shown to be more important than expected on a clinical level. And they found the top 5 most important variables were the antibiotic treatment and the albumin and BUN levels. Occasionally, models have demonstrated that they give more weight than expected to certain variables, which could help with optimization of patient care protocols, for example. In the summary, they mentioned that the top 5 variables of the model were consistent with mainstream research, which helped reassure them that the model was reasonable and that they accomplished their goal of developing a simple and accurate model for predicting community-acquired pneumonia mortality with machine learning techniques. Today you read a medical article based on machine learning and understood the key concepts. Congratulations. Thanks for joining me today, and I look forward to seeing you next time.